My name is Vishwanath. For those who don't know me, I'm the director, Licum Key Professor of Health Communications, and more germane, I'm the director of the Licum Center for Health and Happiness, which is the host for today's continuing series of webinars or seminars. So this year, we have been. There are a lot of. There's a lot of background to the center, and we hold these monthly seminars. We have been doing it for several years, and this year we have been focusing a lot on the social problem of loneliness and connections as a part of our discussion around well-being and happiness. And we have had some very prominent speakers. Some of you have attended those talks, and if not, feel free to go to the website. Dr. Julianne Holt-Lunsted, who was the Chief Scientific Advisor for the Office of Surgeon General on the Loneliness Report. We had Dr. Louise Hockley, and we have a few other people coming in to talk about it. I'm just thrilled to introduce and welcome Dr. Koichiro Shiba back to the school. I have known Koichiro for several years. I think we first met in Japan when I was invited to give a talk with a group there. I think you were working with them, the JHS group, and then Koichiro buttonholed me on a train journey. I couldn't get out, so he was sitting right beside me and said, okay, tell me about the Harvard program. So we had this great conversation, and I have always been impressed with the work he has been doing as a part of this. His interests are manifold, but in two streams. One of them is methodological. He's been doing a lot of work on causal inference and methods development, and I think you will share some of that today. But he has also focused on well-being research, particularly around loneliness and social connections. So it's a great fit. You're going to bring both of them together, and he has done a lot of work on social. It takes a social determinants of health framework in all his work. So welcome back. I'm saying welcome back because maybe not everyone knows this, but his PhD is from our department, our school. So we are very proud of him, of what he has been doing over the last years. It's a delight to have you here.
Thank you. Thank you, and good afternoon, everyone. Really great to be back at my academic home and see some familiar faces. And really thank you to Vision Center for having me and for this wonderful opportunity to share my recent work on social connectedness. Now, I want to begin by sharing the two takeaway messages from today's talk. And really the goal of this talk is to convince you of the following two arguments. Number one is that promoting social connectedness has the potential to reduce health disparities. But number two, the current evidence and methodology that's available in the field is somewhat inadequate for us to support the first argument empirically. So what I'm going to do is I'm going to begin with the second point, and I'm going to give you some background of the field and walk you through the existing evidence and its limitations. And then I'm going to talk about findings from my recent work using a new analytical framework that I'm proposing that hopefully addresses some of the limitations of the past work and then demonstrate promoting social connectedness could reduce health disparities. So just backgrounds, probably at this point of seminar series, you're aware that addressing social disconnectedness is an emerging policy agenda. So for example, the United Kingdom and Japan have recently appointed ministers for loneliness. And in the United States, the U.S. Surgeon General's advisory published this report really highlighting the importance of social connections. And WHO, the World Health Organization, is basically saying that loneliness is a global health priority. So what we are seeing here is that decision makers worldwide are starting to recognize that addressing social disconnectedness is an important thing to do. But why now, right? Why is it receiving so much attention nowadays? And I think there are two primary reasons. Right? One is that there is an increasing trend in disconnectedness. There are tons of empirical data supporting this, and there are many factors that could explain this sort of upward trend in disconnectedness. For example, you can think of changes in household structure, urbanization, or of course, the COVID-19 pandemic, which fundamentally altered our lives. And now many people, including myself, spend a lot of time being alone, working from home. So there's an increase in the number of people experiencing disconnectedness. So that's number one. Number two is that social disconnectedness can have serious adverse consequences. So one is that it can have serious health consequences. And some of the health effects of disconnectedness are somewhat straightforward, right? Like you can think of a situation where disconnectedness can negatively influence your mental health and psychological well-being. That's straightforward. But evidence suggests that the effects of disconnectedness can go beyond those outcomes that you might typically expect. And in fact, disconnectedness can influence negatively our physical health and cognitive health as well. So that's health effects. And also, disconnectedness can influence more broader societal outcomes. So it can negatively impact our economic outcomes, right, in the society. It can decreases neighborhood safety levels. It can reduce communities' disaster preparedness and resilience, which can have, adverse consequences in the time of crisis. So what I'm trying to argue here is that promoting social connectedness is not just about yourself being healthy when you're connected. It's also about our society being better off with strong ties and integration. And that's exactly why we should be promoting connectedness at the societal level. And I'm going to get back to this point shortly. A little bit more about the health impacts of social disconnectedness. I'm not going to do really in-depth review of the literature because there are so many papers on this topic. But I want to highlight these 3 studies that I did with my colleagues. One was in Japan, one was in the US, and one in the UK. So really looking at 3 different populations. And in these studies, we used what we call an outcome-wide analytic approach, where we basically looked at the association between disconnectedness and basically a bunch of outcomes, right? Various outcomes across domains of health and well-being. And what we found was that across the 3 different populations, disconnection was consistently associated with many outcomes, right? So it was associated with impaired mental health, psychological well-being, of course, but it was also associated with impaired physical and cognitive health. So that's really the evidence suggesting that impacts of disconnectedness can have, can be wide-ranging, basically. Now, when we think about ways to promote social connectedness, I argue that we need to go beyond sort of individualistic approaches, right? We should do better than just simply telling people that you should be connected because that's good for you, right? We should do better than that. And we should be using population approaches to promote connectedness at the societal level. And this is critical because, like I said earlier, it can bring us some societal benefits. And it can bring us greater population health benefits. Like if you think about this idea of population approach versus high-risk approach by Jeffrey Rose, that's obvious, right? And there are structural barriers and upstream causes of social disconnectedness. And we need more structural approaches, population-based approaches to tackle these problems. Now, with that in mind, the US Surgeon General advisory report, it has proposed the following 6 pillars, and each pillar suggests approaches to promote connectedness at the societal level. So what I'm going to do is share with you some empirical works that align with these 3 pillars, just to give you examples of what are the ways to promote connectedness at the societal level. So the first pillar is really about designing a social infrastructure in local communities. And I want to talk about this example of community gathering places where older adults can get together and congregate, engage in lots of activities, and make new friends. Okay? Just to give you some backgrounds, the Japanese government over the past decade, they have been sort of encouraging local communities to open this kind of community-based places as a strategy to promote healthy aging. And what we did was, again, using an outcome-wide analytic approach, we basically examined the effects of participation in such community-based places. And what we found was that the participation in these places was associated with, first of all, increased connectedness, right? And also it was associated with improved health and well-being, mental health, cognitive health, and physical health. So this is very promising evidence that there is a way to promote connectedness, which can in turn affect our health. Another pillar is about implementing pro-connection policy. Okay? And I want to talk about this example of post-disaster displacement. So as you can probably imagine, after major disasters like earthquake and hurricanes, sometimes people lose their homes and they are forced to relocate to new places. And by doing that, they tend to lose their existing social connections, right? Because they're moving to kind of new places that they are not familiar with. And that's exactly what happened after the 2011 Japanese massive earthquake and tsunami. A lot of people lost their homes. They moved to temporary shelters like this, and then lost their connections. Now, what's interesting about this example is that in Japan, those areas affected by the tsunami, there were 2 major types of relocation, right, to the temporary shelter. One was to relocate to the shelters as a group, right, with their neighbors in the pre-existing communities. So that's one. Another one was to move to temporary shelters individually. So there are 2 major types of post-disaster relocation. And there is an empirical evidence suggesting that the group relocation actually preserved or even strengthened their social connectedness, among disaster survivors, which in turn protected against, adverse health consequences of disaster. So that's another example. Another way to promote connectedness is to leverage technology and sort of facilitate online social interactions. Now, I want to say evidence in this area is somewhat mixed, but I conducted 2 outcome-wide studies, one looking at the internet use as an exposure, and one looking at online religious participation during the COVID-19 lockdown period. And in both studies, we found that these exposures did not seem to be associated with most of the health and well-being outcomes. Now, I want to be clear here that I am not claiming that online social interaction is not a way to go, right? It's not hopeless, right? I think what this line of evidence is suggesting us is that the experience of online social interactions that we have access to now is not fully replicating the health promoting aspect of our in-person social interactions. So I think we need more research on sort of identifying what are the health promoting aspects of our in-person social life is, and how to replicate that experience using, rapidly evolving technology. So this is something, that need more research. But I think so far so good, right? We have some evidence suggesting that the health impacts of social disconnectedness, and also some ways to promote connectedness. Now, with this, it's tempting to say that this sounds great, right? Why do we do it? We should do it. We should do the intervention to promote social connectedness. Before we do that, there's one big problem that we have not addressed. And you may be thinking that, these are observational studies. Is it causal? Whatever compounding, selection bias, is the measurement value, that kind of thing. That I don't want to talk about it today. Because these are very important things to consider, but that is not the point I am trying to make. The point is, this line of causal evidence is not answering one very important question that we care about as a public health community, which is this, right? So I don't think I need to justify that this is an important question, right? Given the audience, this is important. But the problem is that the current paradigm in causal inference is not really answering this important question. And here's why. So in causal inference, right? I don't think I need to go over the basics of the causal inference today, but I think it's important to recognize that what we are trying to estimate in causal inference is what we call average treatment effect. And we do so by considering counterfactual scenarios where everyone receives the same treatment level, right? So we are sort of imagining a world where everyone is disconnected, where nobody's disconnected. And then, most importantly, the definition of effect is the contrast of two population health averages. Right? So it's the contrast of averages. And I think this definition of the effect is somewhat problematic if we were to consider the implications of disconnectedness on disparities. So the reason is that different exposures may have the same average effect, but have different implications for health disparities. So this one right here is the reference value, and these two are, this one's exposure 1, this one's exposure 2. Now, these are the hypothetical distribution of an outcome under counterfactual scenarios. And if you focus on the centers of the distributions, that's the population average, right? Population health average. And if you compare the averages, that's the definition of the average effect. So if you compare the reference value to the means for each exposure, you get the identical causal effect for the two different exposures. But if you look at the variance of the distribution of the health outcome, this one, it should be red. It was supposed to be red, but this distribution has a wider, right, distribution, meaning that the greater variance compared to the blue one in the middle, and even the reference group. So what this means is that if we only rely on the average effect when we decide on whether or not we should be intervening in these exposures, we may say, well, exposure 1, which is the red one, seems great because it can improve health on average, but doing so, we may end up widening existing health disparities. And that is something we do not want to do, right, as a public health community. So we need a paradigm shift in how we ask questions in causal inference research. And that is because, like I mentioned, improved average health doesn't mean decreased health disparities. We need to consider how the magnitude of disparities might change under a hypothetical intervention in an exposure. And this particular effect, I call it disparity effect. And if we were to estimate disparity effect, there are two key ingredients of the effect, like two key considerations. One is effect heterogeneity. So, for example, if you think about social connectedness as an example, social connectedness, well, more precisely, social disconnectedness can be more harmful among people from socially marginalized backgrounds. Because, for example, they may be lacking some necessary resources to cope with psychological distress coming from the disconnection exposure. In which case, if we promote connectedness in the population, that intervention will benefit those from socially marginalized groups more and potentially narrow the disparity in health in our society. So that's number one, effect heterogeneity. Number two, exposure distributions. And what I mean by this is that the population distribution of the exposure can also be socially patterned, right? So again, using social disconnectedness as an example, it's often the case that people from marginalized backgrounds are more likely to experience health damaging exposures like disconnectedness. In which case, if we implement an intervention that sort of take out the toxic exposure, disconnectedness from the population, that will also benefit people from marginalized groups more, because those are the people whose exposure status is going to be manipulated by the exposure. Right? You need to be exposed if you were to benefit from the intervention removing the exposure. Does that make sense? And so that's exposure distribution. But what I just said about the second piece may not always hold, right? And it does not hold when an intervention does not address the disparity in the exposure. So, for example, you can think of a situation where an intervention promotes connectedness only among people from privileged backgrounds, and socially marginalized groups, they're sort of left behind and stay disconnected. In which case, if you implement that intervention, you would end up widening disparity in the population, even though it will improve population health on average. Okay? Now, so what that means is that it's extremely important for us to think about A, how the exposure is distributed in the population, right? And B, how the intervention might change the exposure distribution in the population. Now, if you think about the current paradigm in causal inference, this kind of nuance is completely missing, right? Because if you compare two counterfactual scenarios, everyone's exposed, everyone's unexposed. It ignores the fact that the exposure itself is socially patterned in the population, and it ignores the fact that the intervention can decrease or increase disparities in exposure in the population. So that's a big methodological gap in the field. And in reality, these two different concepts occur simultaneously. So we need a method to address the both ingredients simultaneously, right? And that is exactly what I'm proposing here. I don't know why. But here point is that, I talked about two key ingredients, right, of disparity effect. And if you look at the methodology research literature, people have already proposed methods to address each of the ingredients. Right? So there are ways to estimate heterogeneous effect. There are ways to affect the effect of shifting the exposure distribution as opposed to fixing everyone's to the same value of the exposure. Okay? The second piece is, by the way, called interventional effect or stochastic interventional effect. So you may want to look it up if you're interested. But the point is that because these method developments kind of occurred separately in the field, they have not been kind of combined yet. And more importantly, these methods, at the end of the day, they are estimating, they're comparing population averages, not disparities. So here, we are proposing a new analytical framework that basically puts the pieces together to estimate the expected changes in health disparities, not population average, health disparities under hypothetical intervention in exposure. So what I want to do is to show some of the findings from my recent work looking at the effect of reducing social isolation on disparities in cognitive functioning. And I want to give a shout out to my amazing RAs who helped me with this project. Toshi is a master's student at BU, and Cici is a doctoral student at Hopkins. And what we did was that we used data of older adults living in the US from the HRS, Health and Retirement Study. And our exposure of interest was, again, social isolation, which was defined based on multiple items capturing sort of the structural aspect of our social connectedness. Our outcome was cognitive functioning scores, where higher scores mean higher cognitive functioning. And we used a bunch of fancy methods to do the statistical analysis, and I'm not going to give you technical details of those methods today. But one thing I want to highlight today is that we used a machine learning-based method to estimate somewhat complicated heterogeneous effect of social isolation, which is called causal forest here. And what's unique about this method is that it basically gives you an effect estimate of social isolation for every single individual in your data. Okay. Typically, causal inference, you get single numeric number for the causal effect. That's the average effect. Here, you're getting different numbers for every single individual in your data. With that, you get to see the nice distribution of the effect estimate. Hopefully, you'll see that in the slides. If not, I'll explain it verbally. But technically speaking, this method is not really estimating individual level causal effect. But I think that's sort of the big picture intuition of what the method is doing. And the ultimate goal of this project was to, again, estimate the expected changes in health disparities in cognitive functioning under hypothetical intervention targeting social isolation. Okay? We looked at different types of disparity. We looked at disparity in cognitive functioning by income, by wealth, by education, by race, ethnicity. Just in the interest of time, I'm just going to show you findings about income-based disparities today. So here's what we found. So this is purely descriptive data from our analytic sample, showing that there is somewhat linear relationship between income and cognitive functioning. Right? The higher the income is, the higher the cognitive functioning is. Okay? So this is really showing the evidence of income-based disparity in the outcome. And we're going to see how this outcome disparity might change under hypothetical interventions. So that's the goal of this study, right? Now, moving on to one of the two key ingredients of the disparity effect, I'll start with the effect heterogeneity. So, like I said, we estimated heterogeneous effect of social isolation on cognitive functioning using machine learning-based method. And here's what we found. So what you see here is that you are supposed to be seeing dotted line here, which represents ATE, so the center of the distribution, which was negative 0.23, meaning that social isolation was on average associated with lower cognitive functioning. Okay? So it's saying that social disconnectedness was bad for you, right? But around that, you see a distribution of estimated effects, right? So this is suggesting that the effect of social isolation differed across individuals, i.e. effect heterogeneity. Now, if you look at the left tail of the distribution, those are the people with greater effect sizes, meaning that for those individuals, social isolation seemed to be more harmful. And if you look at who they are, these are the individuals characterized by lower socioeconomic status, black race, female sex, and pre-existing health problems. So this is what we found about effect heterogeneity. Now, moving on to the other ingredient of disparity effect, exposure disparity. So again, this is purely descriptive result showing that lower income was associated with more social isolation, right? And so this is suggesting there was a disparity, income-based disparity in the exposure as well. And if you look at the slope of this line, that indicates the magnitude of disparity, right? So if the slope is steeper, it means that there is greater income-based disparity in the exposure. If the slope is shallower, it means that the disparity is smaller, right? But what we did, basically, was to simulate exposure status under various hypothetical interventional scenarios. So basically, we created new columns in our data for predicted exposure status under each scenario using some sort of probabilistic models. And then here, I plotted the distribution of the simulated exposures. So for example, just give you one example. You are supposed to be seeing red line right here. So under this scenario, we are imagining an intervention that eliminates all the exposure in the population. So the simulated exposure should look like this, right? For all income group, it's 0. Eliminating exposure disparity, it looks like this, okay? So, and this one looks like it's not completely flat, but it's almost flat, right? So what that means is that for these 3 scenarios, simulated exposure status have flatter slope, meaning that income-based disparity in the exposure was reduced under these scenarios. It's just a simulation, right? For this one, you're supposed to be seeing this kind of line, parallel line for the simulated exposure, meaning that under this scenario, the intervention reduced social isolation exposure in terms of the absolute number, right? There's a reduction in the number of people experiencing isolation, but it kept the disparity in the exposure distribution. Okay, so those are the scenarios we considered, and what we found was this. So you may have seen this kind of figure, right? In the epidemiological literature, it's common to plot effect estimates like this. The difference here is that x-axis corresponds to SII, which is slope index of inequality. And it is a common measure, summary metric that people commonly use to quantify income-based health disparity. So basically, this x-axis corresponds to income-based disparity in the outcome, cognitive functioning, not the average health levels. Okay? So if you look at the first 3 scenarios, you see some reductions in the income-based disparity in the outcome. Okay? So left side, it means reduced disparity in the outcome. So there are some reductions in the outcome disparity. And remember that these are the interventions where they reduced the income-based exposure disparity. Okay? Now, if you look at the last one, this is a scenario where the intervention, hypothetical intervention, reduced the absolute number of social isolation, but it did not address the income-based disparity in the exposure. You still see some reduction compared to the existing disparity, but that is because there was effect heterogeneity where people with lower income were more likely to be damaged by isolation. So if you take that out from the population, people with lower income will benefit more. So that's what this is suggesting. But if you compare the magnitude of change compared to the other 3 scenarios, it's smaller. And that is because the last scenario did not address the exposure disparity in the population. So It was just one case study looking at one specific outcome, cognitive functioning. And, we need more research, of course, but I think what this is suggesting is that promoting connectedness has the potential to reduce health disparities. And I think I argue that we need more evidence of this kind, looking at the expected changes in health disparities corresponding to changes in the exposure distribution under hypothetical interventions, disparity effects. And to do that, we need to consider two things, right? One is heterogeneous effects, one is distributions of the exposure itself, connectedness, and how that is going to be manipulated by the intervention. And I showed a sort of unified analytical framework that allow you to consider both of them simultaneously. So if you're interested in this line of research, either methodologically or substantively, my email is down there, so feel free to email me, and I'm happy to chat, and I'm keen to collaborate. With that, I'm gonna stop here, and I'm happy to take questions from the audience.
Question. In your analyses, you were looking at the ATE, and what are your thoughts on looking at ATE as opposed to ATT when, in fact, you wanting to remove loneliness among those who are lonely, particularly with intervening and kind of policies that would be targeting those populations in particular?
Sure. Yeah, I mean, that's a wonderful point, right? If you think about the interventions where you remove harmful exposures from people who are already exposed, you should be looking at ATT instead of ATE, right? I 100% agree. And if you think about where ATT would look like, I think I would say it's going to be something around here, right? Because remember, people who are exposed were more likely to be from socially marginalized background. Right? So in this case, they were from lower economic background, lower income. And that's exactly who they are. So exposed people they tend to be somewhere around here. So if you estimate ATT, it's going to be somewhere around here. Does that make sense? But yeah, I agree. ATT might be more policy relevant if you're interested in removing the exposure. Yeah.
Is it reasonable to assume that on the other end of that distribution, the opposite of the vulnerable individuals' characteristics, like high income, high education, wherein being socially isolated is actually a benefit to one's health?
Yeah, that's a great question. So in the paper, we compared characteristics of those people and this tail, right? And we found that these people, exactly, they are from more advantageous backgrounds. They had higher income, higher education, racial majority, stuff like that. That is not always the case, but in this particular example, that was the case. Now, in terms of effect estimate, these people, right? Is social isolation beneficial for those people? That I don't know. I mean, with finite sample size, sometimes you get funky estimates, and maybe some sort of function of that. Maybe for some people, being isolated can be beneficial, but I don't know how that generalizable based on this finding is. But yeah, good question.
Can I just follow up? How would you get at that question? Because that seems really fundamentally important question, especially coming through COVID and all, and in the sense of with the effect of isolation on everyone being profoundly challenging. So I would wonder from your perspective, how would you look into that to kind of more calculate what the effect would be on the effect on anyone. I mean the positive benefits for anyone on a
So I think this is a great point. So our exposure in this study is social isolation, right? Social isolation is actually, I have a slide on that. Social isolation is capturing the structure aspect of the social connectedness. And not everyone suffers from social isolation. Some people like to be isolated, right? And that's okay, as long as they don't feel lonely, which is the functional aspect of social connectedness. So I think for some people, social isolation is not strongly linked to loneliness. So for those people, social connectedness may not be that harmful or even beneficial if they really like it. Okay? So if they like being isolated, not connected with friends and family, they may not feel lonely, right? Because loneliness is really about the discrepancy between their expectation about their social connectedness and the reality. If their expectation is that they don't want to, I don't want to be connected, then they don't feel lonely. So they may not have experienced the negative health consequences of social isolation. Yeah.
Clarify the scenario where you're intervening such that there's kind of like a uniform impact across the like initial prescription spectrum, right? So in this case it's income. So are you eliminating the proportion of the social isolation experienced by like the stratum in which it's lowest? So like let's say at the highest income rung, few people are experiencing social isolation. Is that the target across all rungs of income? Or are you saying that like your proportion increases by 50%?
This one?
Yes.
So what this means is that for each income decile, the intervention decreases the prevalence of isolation by half. So for the poorest people, it's going to be half. So it's going to be somewhere around here. For these people, income 2, it's going to be like here, 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 here. So you keep going. So for across all income deciles, the prevalence of social isolation is half under this simulation.
So is that scenario like the expected effective treatment under that scenario? Is that recovering confounding? Like essentially, if there's non-random distribution of the social isolation in the population based on income, and therefore if you ignore income in eliminating social isolation, you're essentially recovering that, like, there is no impact of tackling social isolation.
So confounding piece is addressed in the phase of heterogeneous effect estimation. So when we estimate heterogeneous effect, we adjust for confounding, etc., right? And that's taken care of. Now we are using the effect estimate as well as the simulated exposure distribution to simulate the outcome distribution under each scenario. Right? So I don't know if you know what G formula is, but if you know what it is, like basically standardization, you have columns for exposure, and then you specify everyone to be 0, and then 1, and then you predict outcome, right? That's the G formula. Here, we are doing somewhat more complex, right? So instead of specifying everyone to be 0, you are allowing the exposure to be distributed across individuals under hypothetical counterfactual scenario. But everything else is going to be same, right? You are manipulating exposure status in G formula, but that is not going to introduce confounding because you already adjusted for confounding when you estimated effect.
Okay. So you're recovering like that you would still see disparity in the population if you apply this kind of within distribution like treatment.
Mm-hmm.
We'll take one more question. Actually, I saw your hand.
Yeah, Thank you. This was a great conversation. I was curious about the evidence that we have on, like you did a simulation on reducing social isolation, but how would you summarize our current evidence about our ability to
Interventions on social isolation, right? So I talked about a couple of evidence in empirical works, kind of about ways to promote social connectedness, right? So, for example, building community gathering places is one way to go. Post-disaster displacement, or perhaps in the future, online communication might be a way to promote social connectedness. Now, these are the evidence that suggest it could promote social connectedness on average. And these line of evidence, they are not telling us whether the intervention is this or that or that or that, right? Because how the distribution within the population by income, right, might change under the intervention is not something you can know from the type of evidence I just showed you, because it's looking at the average change in social connectedness. So I think we need more evidence looking at how the interventions, actions might influence our connectedness differently across individuals. You see what I'm saying? So that line of evidence is completely lacking in my opinion. So it's hard to say that whether interventions can actually address social interaction at this moment. Yeah.
Any other questions? Great, thank you so much.
Thank you.
Thank you.